Okay, good. Yes, we're going to be talking about, in general, the impact of cochlear implantation on quality of life in older adults. Move on. It's just my disclosures uh, for the research. So, our research program focuses a lot on quality of life, and that's really the centerpiece of our work that we do. And we developed the cochlear implant quality of life instruments, and they were finally validated in 2019, and they're available in about 10 languages on our research website. They've been downloaded, by over, 1,600 unique individuals. So becoming more and more used. And this is kind of, a lot of what I'll talk about is the development of these and how they kind of the impact that age plays in quality of life outcomes. So, if you mind the next slide. And so first, kind of as mentioned before, cochlear implant surgery is very safe in all patients, but it's very, very safe in older patients. And I tell every patient that the hardest part of the cochlear implant process is not the surgery. The surgery is very straightforward. It's very safe. It's very established surgery. The anesthetic exposure poses minimal risk, but really it's that hard work afterwards. That's where the hard work comes into play. So I always say, as a surgeon, I give my effort at one moment, and the patient's giving their effort kind of over the next several months and years, and really the rest of their lives. If we look at kind of cochlear implant outcomes, they are measured typically using speech recognition testings. And here you can see these numbers from a meta-analysis of kind of, before surgery to after surgery. You see these improvements in words and quiet, sentences and quiet, and sentences and noise. You can go to the next slide. But we can see that there's a tremendous amount of, back one. Tremendous amount of variability, and this is the standard deviation. So there's a lot of variability in speech recognition outcomes among individuals. But kind of, go to the next slide, Leo. But we know kind of how someone does in an audio booth doesn't really correlate well with how they do in the real world, right? That's not the real world. Even if you kind of introduce background noise and try to simulate kind of normal listening environments, it really does not correlate with patients' real world communication abilities. And next slide. And kind of research that we have done and others have consistently demonstrated this, that, how someone does in the audio booth only accounts for somewhere between 4 to 16% of the variance in patients' self-reported communication ability. So kind of focusing solely on these speech recognition scores really kind of only provides a very, very small glimpse of how that person's doing, and it really does not, correspond to how they do in the real world. You go to the next slide. And so, we started this process of developing these instruments. We did a series of focus groups. And these were kind of patients with a wide range of ages. We had young patients, we had older patients, we had patients who were traditional high performers, low performers. And out of those focus groups, there were essentially 7 different domains or primary themes that arose. And those were, patients noticed improvements in communication. They noticed improvements in emotional state, in their social interactions, in their, environmental sound awareness, improvements in listening effort, improvements in entertainment, ability to hear sound, music, TV. But the one kind of, go to the next slide, the one we'll focus on really here is the functional independence. And that was a major role, especially in that older population, of kind of that improvement in those individuals' functional independence. So here were kind of some of those sub themes that came out from the focus group. So, these themes are things that were consistently said were, I am now able to drive when necessary. I am able to drive without assistance. I'm able to go shopping without assistance, which is a major driver of improvement in quality of life. Next, the improvement in feeling handicapped by their hearing loss. And sorry, go back. And I can live by myself without assistance. I'm able to function independently. Right. And then these are really major quality of life improvements. And these were very consistent among many, many different patients, many different populations. But unfortunately, you go to the next slide, Leo. As we were developing the instruments, it was a measurement issue where the functional independence did not become one of the domains for the cochlear implant quality of life instruments. And that was just it had nothing to do with the fact that it wasn't a major improvement in the patient's quality of life. It was really from a measurement characteristic standpoint. that it didn't meet the kind of criteria that have been established to be a domain within a quality of life instrument. So it ended up leaving the quality of life instrument, but all the other domains remained. So then, we kind of did some research into looking at, how can cochlear implant, how do cochlear implant quality of life outcomes differ based on age? And so we did a study of 371 adults who are implanted across the United States. Mean age was 60, so the standard deviation was plus or minus 15 years. So this was quite a large age range. So we had kind of a lot of older patients and a lot of but some of the maybe kind of middle-aged patients as well was the primary demographic. And we looked at whether demographic factors or kind of a range of demographic factors. We looked at urban status of living in an urban versus rural versus suburban environment. We looked at household income. We looked at whether or not the patient was employed, who lived in the house, and then looked at hearing factors as well. And we looked at a whole series, and we controlled for all these factors as we looked into this, and looked at baseline hearing, overall improvement in speech recognition scores, and then we looked at what impact did that have on cochlear implant quality of life outcomes. Okay, so first of all, when we looked at the impact of age, there was actually no difference in the improvement that patients got for the communication domains, for the emotional domains, for the environment domains, for the listening effort domains, or for the social domains. So no matter whether the age of the patient had absolutely no impact on those outcomes. However, we did see patients who were older did have decreased improvement with regard to the entertainment domain. Okay, so patients did work. But it's important to think about when we look at this of what is the overall effect size, right? There's a statistical significance finding, but what does that really mean with regard to kind of functional ability? So, not to go into statistics, but the beta value for this was a negative 0.3. So this means that for every year of increased age, a patient's entertainment domain score decreased by 0.3. So what does this mean in reality? Go to the next slide, Leo. This means that you'd have to have a 45 age difference to have a meaningful change in someone's cochlear implant quality of life score. So basically, you'd have to have someone be 45 years difference before you really notice a change in that entertainment domain score that has a meaningful difference into it. So while, yes, the scores were statistically different based on age, the real world effects of that are probably very, very, very small. And so kind of we look at the cochlear implant outcomes in older adults, quality of life outcomes, we see minimal quality of life differences between older and younger CI users. And this has been very consistently shown. As Dr. Bierman kind of did notice, there may be some small differences in speech recognition scores and in certain age groups, but overall, those differences in speech recognition scores are all overall pretty small. And the impacts on patients' daily life, as we've shown kind of in our focus groups, are very widespread and cover all the communication CIICA domains. So I was very appreciative of our team that kind of does this research and our research consortium who helped enroll patients for these studies.